you all are super involved in training and guiding that next generation of professionals into the workforce. What do you hear from them? What do they tell you is in their way mentally? What are they fearful about? What are they worried about as they come into this field?
So I can start. So, I work with people who've already completed their training or in the process of completing their training. And one of the big things that we hear are the concerns over staffing. So they've heard a lot about short staffing and long hours. And so as they come to us, they're concerned about that. And also the younger folks that are coming out of school now are very concerned about time off and how much time off. That seems to be an important consideration to people coming into the workforce.
Wow, no kidding.
So I have a little bit different story. I run Dwyer Workforce Development, which is a nonprofit, and we train people who lack opportunity to be certified nursing assistants. And the biggest challenge with that is the fact that if you have the same barriers to success that you had before you got a job and you don't have anything that changes, you're still going to have a problem retaining a job. So we spend a lot of time with person-centered case management and wraparound services that support what we call our Dwyer Scholars, and we also give them a career path to do whatever they want to do after their CNA. So I think the challenge for my Dwyer Scholars is the lack of resources.
I think, so I'm the Dean of the Johns Hopkins School of Nursing, and so our students come from all over the country. They're really excited about nursing. And one of the wonderful things about nursing is there's so many ways to interact with it, including starting as a CNA and working your way up. And unfortunately, 27% of nurses leave in their first year or two of nursing. And so that is something, as a nation, we really need to tackle. There's 4 million nurses in the country. It's more than any of the other health professions put together. If you add up all of the doctors, the social workers, the occupational therapists, everyone together, there's more nurses. So part of what we need to do is create pathways similar to what you're talking about that are tailored and individualized for each person. We get people who come to us from social work, for example, or they've been an EMT. When we have circus performers and lawyers and all kinds of people who come to Johns Hopkins to become a nurse. And we're working on really individualizing their learning experience, partly by traditional teaching, partly by simulation, either with VR or AR or with trained actors, and what they can do in groups so that people can work as hard as they need to get through. And so some people's path will be shorter, some will be longer, but that way they will all be really ready for practice. And if you think about our educational institutions, a semester is the same length for everyone, and college is the same length for everyone, but what you learn could be huge or small or something in the middle. We're trying to flip that so that everyone learns the whole amount and the time could be variable.
Yeah, and are you finding that, and obviously, Lisa, you mentioned that a new concern that you're hearing on the ground is about time off and hours and commitment. Would you say that that's a recent change of mind? Would you say that's a pandemic thing? Is it, and how have those concerns sort of changed in the last few years, just given what we've all lived through, and especially in healthcare?
Yeah, I think it's a little bit of both. So I think it's a generational thing. I also think the pandemic caused people to rethink healthcare in general and the demands of healthcare. A lot of people got out of healthcare during the pandemic and went to other careers. And so that kind of created some of the problems that we are experiencing now in terms of staffing supply. And that's why partnerships are so much more important now than they've ever been to create that supply coming in from the beginning, even from the high school level, to entice them to get into the health careers. And that's why working with companies like we actually work with Barb's company to create a supply for CNAs coming into our skilled facility.
But I'd like to jump in just for a minute, and then I'll turn it over to you. I think it's actually a healthy thing. I think that nurses over generations have thought it was a good thing that they didn't stop to go to the bathroom, they didn't take vacation time, their patients were always coming before them. I think to be a sustainable profession and to have a sustainable life, we do need time off, and we do need to take care of ourselves. And I think there's a lot of innovative health systems that are looking at 4-hour shifts for older, nurses. We have alumni who I met recently who are in their 80s who are still working.
Wow.
And they love it, and they work at places that have variable shifts and different roles for them. And so I think that this generation is actually helping us rethink what work should look like.
And I will add, we just had a nurse at one of our hospitals that just celebrated her 50th anniversary in nursing at our hospital. So, it's a profession, it's a career that people come into, and I always say nursing is not, what you do, it's who you are. And but I also think that people think in terms of healthcare as doctors and nurses, but there's really so much more than that.
CNAs are absolutely the foundation of nursing. They're the people that do all the hard work, the dirty work, and it's backbreaking sometimes. And for them, many of our Dwyer scholars are single head of household mothers. And, they are trying to raise 2 and 3 children. They're trying to change generational wealth for their families and have first-gen grads. And they're trying to figure out how to go to work every day without the resources they need. So for us, it's not just the hours. For us, it's the whole big ball of wax that we try to address. Because, trying to schlep 3 strollers on a MTA bus and, you get to work and one of your kids is sick and you have to go back and get them, it's just insurmountable. So, some of the CNAs have so many more challenges.
Yeah, so social services, more wraparound care, that's one way that we can maybe entice more people to enter this profession. What are other specific ways that we can get more people into the field or retain them once they're in?
So for us, it's workforce training programs. I see a lot of focus, we're in Texas, Florida, and Maryland, and I see a lot of focus on getting nurses. Well, where do you get them if you don't have a pipeline of people? And so we have seen a lot of success with the workforce training program where you start, somebody has a CNA, you take them to the next step in careers at 9 months. We have a career counselor that reaches out to them and gives them a chance to upskill. And we'll take them all the way through RN and LPN. And that is a really good pipeline for this catastrophic healthcare staffing crisis that we're facing.
And we actually, many organizations, including ours, are starting high school. We're reaching out, starting apprenticeship programs in hospitals in high schools that are in our communities, and starting to develop those, that interest in health careers and exposure into hospitals and other healthcare situations. Starts that young.
I'd like to mention 2 things that we're doing. So at Johns Hopkins, 2 things are relevant here. We train people for the current health system, but I feel as our role as leaders, we're the #1 school of nursing in the country, and we're looked to, thank you, we're looked to as how to help change the future. So we're partly thinking about, okay, how do we graduate people, in May, but we're also thinking, what is the health system that more and more nurses and doctors and social workers and nursing assistants would want to work in? And so together with Morgan State and Coppin State and University of Maryland, we've developed a model called neighborhood nursing that is based on Costa Rica. So Costa Rica had not very good health outcomes until the 1990s, and then they put into place a plan where everyone has a nurse and a tech by a zone. So if you all lived on the same block, if this was a block, you'd have the same nurse and community health worker who would come to see you, who would get to know you, who would know you longitudinally. You could reach them by text or app. And we're starting to do that in Baltimore. It's based, for those of you who were here for the first panel, when they talked about how the healthcare system is different in Maryland, it's the way this would work sustainably would be that all the payers would pay in over time because it would save money and it's common sense. And so we think more nurses would want to work if in nursing, if there's all kinds of roles for them. Currently, only 60% of nurses work in hospitals, and we tend to think that 90% do, so that other 40% is in other places. They're in schools, they're in clinics, they're in homeless shelters, they're in senior high-rises. But we think as we build out that system, more and more people will want to become nurses. The other thing I want to mention is that we have one nurse for every 81 Americans already. And that should actually be enough if you think about our health. It's just that we have such a reactive, fractured system that we need more. We always are needing more and more and more. But if one nurse in a hospital has 8 patients or 4 or 2 sometimes, and then you have to staff that around the clock. But if we had a much more preventive system where people didn't need to be in the hospital as much, then that one nurse for 81 Americans would probably be enough.
So I want to ask Lisa, as somebody who's in the hospital business, do you think there's a place for something like a zone model or a community health model and a hospital model, a traditional hospital model?
Absolutely. I mean, I think that's the trend now is more care in the community where people live, more access to care. And so the community health workers have been and are becoming even more important in terms of creating the overall health of the population, because ultimately the goal would be to have a healthier population. Then you need less inpatient health care.
Well, and literally, I had a healthcare administrator, not in Maryland, say to me on Friday from a children's hospital, say, our census was down, and so was the children's hospital in Philly, which is this person, and so we had to look what was happening. Were the vaccines working? And there was a worry, a terror, that the children being hospitalized wasn't happening enough for them to pay their bills. And of course that's a worry if you're thinking about it from paying the bills. You have people to pay and rent to pay and mortgages. But that is backward, right? We should all want to keep people out of the hospital. We always need strong hospitals for when people need to go. But what can we do differently as a society to prevent hospitalizations?
I want to ask about a phenomenon that I'm finding is more and more common with people I talk to, and that's concierge medicine. And for those of you who aren't familiar, that's the practice of paying an upfront fee to have access to a healthcare provider 24/7. And those fees can be astronomical. It's not something where you can have your insurer pay for it. These are out-of-pocket costs, sometimes thousands and thousands of dollars to kind of put a doctor on retainer, so to speak. What are our thoughts on that? And be honest, is that something where you feel like has a place in our healthcare system, or is that something that you would like to see less of down the line?
Well, if you are terrified that there's nobody to take care of you, which is actually true, we'll be short caretakers by over 3 million by the end of next year and 10 million by 2030. So if you're terrified that there's nobody to take care of you, you may as well pay for it, right? Because it's so challenging, but it's not ideal at all, obviously.
I think those systems are a symptom of what's wrong. And that doctors tend to do it if they're frustrated with insurance and billing and how much time they're spending administratively. And patients tend to do it if they don't feel like they can get access. And we can do better. And if we build on something like the neighborhood nursing model, where it's almost like this concierge care but for everybody, then I think that makes more sense and it's more equitable.
And I'll just add, I think access to care obviously is what's driving the rise in this model, and I think the ultimate goal would be to come together as different healthcare entities from schools, from healthcare systems, insurance companies, the whole gamut of healthcare, and help to address the issue with access that we're facing. The numbers that you just gave, those are real and they're staggering. And so we've got to come up with a different model, a different plan to increase access. And I think, but in the meantime, I think you're going to continue to see the interest in concierge medicine increasing.
10,000 people a day turn 65 in the United States, and there are going to be less children than older adults shortly. So that is very symptomatic of what we're looking at.
We have time for one more question, and then we're going to turn it over to Q&A. Sarah, you mentioned insurance becoming more of an issue among the provider network. I've experienced this in my own life, where it's harder to find people with insurance, and I talk to people, out in the community all the time who say, if you have Medicare or Medicaid, your options are slim to none. So what is going on here? And can you explain to the audience what exactly we're talking about when we talk about insurance and what the difficulties are that people are facing?
Well, so Brian Pennick was on the panel right before me. He might have been better at explaining that. But I would say that we sometimes think about insurance as being somebody else's business, but we all pay into Medicaid and Medicare through our wages, and insurance through our wages. And so I really think that Maryland is a super innovative state in terms of getting the insurers to work together. Ohio is also, I'll just mention a quick example. The Secretary of Health for Ohio told all the insurers that their quality kind of bonus was going to be withheld unless maternal morbidity, meaning sickness after pregnancy, was better for the whole state, so not just for their insurers. And so they are starting to work together because they have an incentive to. And I think that insurance always needs to be in balance with the public health of each state. And we've got a long way to go with that, but there's a lot of innovative solutions out there.
And are the two of you finding that when you talk to providers that they're telling you that insurance has become untenable for them, that working with insurers is almost more trouble than it's worth?
Well, there are some specialties where it is, people are just getting out of the insurance business, behavioral health being one of them. They're going to more like a dental care model where it's just easier to take direct pay and the demand's there. So, a lot of it used to, your insurance plan drove who's going to be your provider, but now there's more demand than there are providers, and so they can do that. They can just say, I'm not taking insurance at all. It's a direct pay only.
That doesn't really apply to our workforce model, so I can't speak to it, but I do know it's a challenge.
We're going to turn it over to Zuri now. Zuri is...
Thank you. Questions from the audience. We only have time for maybe 2 if we go fast, okay, here. With the shortage of nurses in traditional healthcare roles, what role could more non-traditional hospital roles play? Those like community health works and midwives.
Well, I think we mentioned community health workers, and we're looking at other support staff and expanding the duties that they can do. I think over time we're going to have to look at some of the licensure requirements on some of the roles and ask ourselves as a community, what are the things that truly have to be done by a nurse or done by a physician. So we're seeing an uptick in roles like advanced practice providers, like nurse practitioners, physician's assistants, and roles like that are becoming increasingly more important.
And this last one is a bit of a comment and a question here for Barb. I don't think CNA positions provide a living wage. In light of the nursing shortage, are there any Hopkins and or LifeBridge programs helping CNAs transition to nurses, either LPN or RN, building the pipeline that you mentioned?
Our program does that. CNAs really don't make a living wage, and it's really sad about that. But we have to meet people where they are, and a lot of our WIRE scholars don't even have GEDs. So if they want to seek a career in healthcare, they can be a CNA, but then one of our challenges now is getting them to that next step and helping them get their GEDs. One of the things we're looking at doing is starting an adult high school to help them move forward in their careers. But once they do get that GED, and some do have it, they can go anywhere they want with us. We can take them, if I get every one of them into a director of nursing position, DON, I would be the happiest woman in the world, because what we're doing is taking somebody that really doesn't have a job or wants a healthcare career and can't afford it, and moving them through and changing their lives for their children and changing generational wealth. So if we could get them there, that would be thrilled.
I do have some more questions, and we do have a little bit more time. Would any of you comment on the role of private equity in healthcare?
I'm sorry, of what? I didn't.
Private equity in healthcare.
Private.
Private equity.
Well, that's interesting because I came from a role prior to being here that was private equity owned and backed. And so I think that it's a little bit of a double-edged sword. I think that the focus has to remain on quality and on the patient experience, and instead of on the finance, and then the rest will follow. But do I think it has a role? I guess it depends on the environment and the focus. So I think private equity, let me just add to that, has put a lot into innovation and startup companies in healthcare, and I do think that has value.
So I also run 64 skilled nursing facilities in Texas, and we acquired those in a nonprofit so that eventually the profits that they throw off will fund the not-for-profit. The first thing I did, they were owned by private equity, PE guys. First thing I did was change them to nonprofit facilities, and we rebranded them, and they are committed to the residents, the employees, and the community. And we're not always looking at the bottom line, but we're looking at how do we spend money to make money, and how do we make the lives of the community, the employee, and the residents better. And it has changed our census. It has increased our census considerably. And so for me, I'm a big believer in nonprofit.
I believe this next question can be directed at Dr. Santon. Since we are an aging society, why are we not graduating geriatricians or CRNPs with a practice in geriatrics?
Did you say why aren't we?
Why aren't we graduating more of them? Yes.
And more of them. Okay, so my background is in aging. We all are aging all the time, but I mean my academic background. And geriatrics is one of the very few specialties where your salary goes down after you do a fellowship. So you go all the way through medical school, and then you do a fellowship, and then your salary is worse than it would have been before the fellowship. And if you want to do geriatric psychiatry, it goes even farther down, which is so sad because, as we all know in some of the other panels, we have such a mental health crisis, and our heads are very related to our bodies. As a school, we have a big aging focus, and we try to make sure that aging curriculum, geriatrics, and gerontology are woven through all of our regular curriculum. But to be able to graduate more, I think we'll either need to do, one of the earlier panels talked about decreasing medical school debt. And if people have no debt when they graduate, then having a lower salary shouldn't matter because it's still beyond the living wage. And so when medical students come out with a lot of debt, they tend to think about the higher income specialties.